Hello everyone, I am Ashlin from Apollo Main Hospital, Chennai. Today I would like to share our experiences on ECMO as bridge to lung transplantation and further. Here we will emphasize newer technologies related to ECMO use before and after lung transplantation. We initiated 5 ECMOs for patients awaiting lung transplantation last year. 3 were female and 2 were males with a minimum age of 24 and maximum of 62 years. Duration of ECMO was 18 to 61 days. Diagnosis included cystic fibrosis and interstitial lung disease. Predominant hypercarbia and hypoxia were the cause of initiating ECMO. Eventually, 2 patients were converted to VAV ECMO due to severe PAH and RV dysfunction. 3 patients needed post-op ECMO support due to primary graft dysfunction. We used CardioHelp and Rotaflow. Here is the picture of a patient shifted for CT scan on ECMO. Cannulation configurations are dual lumen cannula in IJV, left and right femoral vein cannulation, femoral vein IJV cannulation. For VAV ECMO, femoral vein, femoral artery and IJV cannulation were used. Reverse free life cannula used for distal perfusion. Awake and cooperative patients were extubated and continued with HFNC or oxygen mask. Sedatives were weaned off as per patient tolerance. Heparin and bivalirudin used as anticoagulants. Minor bleedings managed with compression dressings and sutures. Significant bleeding needed temporary cessation of anticoagulation. 1 pre-op and 2 post-op patients needed CRRT due to acute renal failure. Hemolysis and systemic inflammatory reactions caused liver dysfunction in ECMO patients. 1 post-op patient developed DAC. This was a DAC profile of that patient. We changed the oxygenator for 1 patient on the 54th day of ECMO. 1 patient got heparin resistance due to antithrombin 3 deficiency. Later, we switched to bivalirudin anticoagulation therapy for this patient. 2 patients got GNP growth in cultures and appropriate antibiotics were given. Resistance and stretching exercises were followed once the patient got awake. Some patients progressed to sitting, standing and eventually walking. Chattering was the most frequent complication we faced during ECMO. We are using an integrated circuit of Sorin 6F oxygenator and PLS kit for transplantation. We put a Y connector to connect 2 venous lines for drainage and inserted an aortic cannula for return. We followed ischemic reperfusion protocol during cross-clamp removal. Then coming to conclusion, 40% of the patient got recovered post-operatively. Further researches on the use of ECMO as bridging strategy and development of evidence-based guidelines are needed to improve patient outcomes. Thank you.